Good morning, everybody. I'm pleased to have this chance to talk to you about this important subject of urgent and emergent hypertension, which is now often shortened and simplified to severe hypertension, although as you'll see, there are strong differences between urgent and emergent hypertension as we go through. So normally I ask a lot of questions and make it highly interactive, but now with the Zoom requirement, that's not so easy to do. So we have got up here on the screen a chat box, and I'd be delighted if you ask some questions, either typed into the chat box or spoken into the microphone, however, but I won't really be able to ask you directly questions. I do illustrate this with several cases, which are very practical cases, and they have questions attached to them. And then I show some of the data relating to it, and we come back and give my answers to my own questions. So I'm afraid it has to go that way this time. Normally I'd ask each of you in turn to comment, but we'll just have to do it that way today. So I'm going to make this case-based. We need the definitions here are really important, as you'll see, because how we decide and define urgent and emergent hypertension depends very much on the treatment. A lot of the underlying physiology is based on autoregulation of the brain and the kidneys and its breakdown during severe hypertension. So we'll talk a little bit about that. We'll go through the clinical aspects of urgent and emergent hypertension. And malignant hypertension is a special form of hypertension emergency, which you'll spend some time on. One thing I think that many people nowadays, many physicians are rather weak at, is examining the eye grounds with an ophthalmoscope. So I'll show you some pictures of eye grounds, normal and different degrees of problems, things to look for in your physical examination, and finish with treatment. Okay, so here's a case of severe hypertension. A patient age 60 with hypertension for 20 years, past history of a myocardial infarction and a CABG 2 years previously. At routine clinical appointment, his blood pressure was 225 over 126 with a heart rate of 62 beats per minute. This is a fairly frequent occurrence for you, either in the clinic or on the ward, to meet a patient then with what you might consider a frighteningly high level of blood pressure. And how you approach that depends very much on the clinical setting and whether you establish a diagnosis of a hypertensive emergency or a hypertensive urgency, and that'll be the point of this case. So he has no symptoms, no other abnormal signs. The urinalysis and the basic metabolic profile were unhelpful. He's known to have hypertension, is treated with a reasonable dose of an ACE inhibitor, ramipril, a calcium channel blocker, amlodipine, and a thiazide diuretic, hydrochlorothiazide. So here are 7 potential issues, potential things that you could do, and we'll go through them and come back and answer these questions when we've seen a bit more data. So because of this very high blood pressure, would you admit the patient to the ICU? And if you like, you could jot down here a Y for yes or an N for no. So one might be 1Y or 1N, and that'll tell you when we come back and look at the answers how well you're doing. Would you give a short-acting calcium channel blocker, nifedipine, in the clinic? And nifedipine can be given as a capsule. It can be bitten and swallowed so that it is very rapidly effective. Would you give the centrally acting drug clonidine, 0.3 milligrams, which is a full dose, in the clinic? Would you choose labetalol, which is a combined alpha-beta blocker, in a reasonable dose? Would you choose hydralazine, a direct-acting vasodilator, in a fairly high dose? Would you write a prescription for chlorthalidone 50 milligrams in place of hydrochlorothiazide 12.5 milligrams? Would you follow up in 1 week in the clinic? And here we would expect to follow this patient in the clinic till his blood pressures come down to a level that's a little bit closer to normal, say 180 millimeters of systolic. So the key management, do we admit this guy for urgent treatment, or do we give him something in the clinic and something to take home and check the blood pressures going in the right direction and send him home and see him in a week? Okay, so we'll come back and answer this together and in a little, in 2 or 3 slides time. So acute severe hypertension is a generic term that includes urgent and emergent. And the key difference is whether there's acute target organ damage. And that doesn't mean chronic target organ deficiency. Let's say a past history of MI is not what we're after. What we're looking for is evidence that a key organ, which mostly is the brain or the kidney or a blood vessel, has been damaged and its function is compromised. So if that's the case, then you diagnose a hypertensive emergency and a whole set of things follow from that. If that's not the case, then you diagnose hypertensive urgency and a whole set of things follow from that. And there's a very current review here in the New England Journal on severe hypertension that I put up here for any of you that want to follow up a little bit more about this later. So if we go back to this patient here, is there acute target organ damage that we see? And the answer is no. He's got past organ damage for sure. He's got severe hypertension for sure. But there were no symptoms or signs suggesting acute target organ damage. And so he does not have a hypertensive emergency, a sudden rise in blood pressure with acute deterioration function of a target organ. But he has a hypertensive urgency, a sudden rise in blood pressure without the acute deterioration in the function of the critical organ. So here's a little bit more information about what to look for. So here's severe hypertension, which is systolic pressure above, let's say, 180 over 110 to 120. And you need to check it on 3 occasions to make sure that it isn't a startle response. The patient's very frightened of something going on in the clinic, whatever it might be. So this is what you need to assess. Are there findings of acute organ damage in the brain? And that would be a stroke, an intracerebral hemorrhage, posterior reversible encephalopathy syndrome, the Press syndrome. In the eye, hemorrhages, exudates, or papilledema. We'll come more to that. In the heart, an acute coronary syndrome or acute decompensated heart failure. In large vessels, aortic dissection, very important, we'll deal with that. In the kidney, acute kidney injury. And in the blood vessels themselves, evidence of vasculitis, usually a microangiopathic hemolytic anemia with schistocytes. Again, we'll say more about each of these. So these are the acute deteriorations in target organs that you that your physical exam and your basic workup, very quick workup in the clinic, if necessary, would be directed towards diagnosing. And if they're not present, then the patient has urgent hypertension If they are present, the patient has emergent hypertension. The treatment is entirely different. With emergent hypertension, the blood pressure must be lowered within minutes or hours to reduce the risk to life or vital organ function. So it follows that drugs must act rapidly and predictably, and that really means parenteral therapy and intensive monitoring. In other words, the patient needs to be admitted to the ICU and very likely requires intra-arterial monitoring and intravenous drug administration. Very, very different if it's urgent hypertension. The blood pressure can be reduced safely over hours or days, and parenteral and intensive monitoring not required. So we come back to this patient that we have in the clinic here, and why we decided that this was a case of urgent, not emergent hypertension, so it does not need to be admitted to the MICU, does need some treatment in the clinic, we'll talk about that, and once the blood pressures come down, can be followed up a week later in the clinic. So nifedipine. I'd be happy if any of you'd like to make a comment here. Any of you would like to give nifedipine in the clinic? Well, let me tell you, that used to be the choice some 15 or 20 years ago. It certainly works very well. However, it works a little too well, and the FDA found a number of cases in which the patient sustained an acute stroke. The blood pressure had gone too far down too quickly. And they issued a red box warning, which means basically don't use the drug unless there's some overwhelming reason to do so. So we no longer recommend it. What about clonidine now? So clonidine, you may think, is a drug that may not be strong enough, may not work well enough. It does actually, it works very well. The blood pressure would almost certainly come down well below 180 within 30 minutes. So in that sense, it's a good drug. It's okay for somebody with cardiac trouble. The one big problem with clonidine, and why it's not my choice, is that people who are not accommodated to it, not taking it regularly, and given a full dose here, become very sleepy. And it's not safe to send this patient home and drive him or herself back to their home after the clinic visit, after a full dose of clonidine. So I wouldn't choose that personally. What about labetalol? Labetalol, I think, is a good drug to use. It's very predictable. It blocks the alpha and beta receptors, and therefore does not cause cardiac stimulation, reflex stimulation when the blood pressure comes down. And there are very few contraindications to its use. Labetalol doesn't slow the heart rate much because it blocks alpha and beta receptors. If the initial heart rate had been in the low 50s or high 40s, I wouldn't have used it, but otherwise, it's a good choice. Hydralazine, I suspect, is what many of you would choose. It seems to be the residents' interns' favorite choice for treating severe hypertension. It's not a bad choice. It would lower the blood pressure. It's a direct-acting vasodilator, but it does cause reflex cardiac stimulation. And this patient has had an MI and a CABG in the past. It's just as well as to avoid that in this particular case, and that's why labetalol may be better. Now you want to send, all of these are short-acting agents, and these drugs either weren't working or they weren't being taken. So we want to give this patient something that's going to ensure that he doesn't have this very high blood pressure return later on that day and be a problem for the rest of the week. So a long-acting thiazide diuretic, chlorthalidone, in a good full dose, 50 milligrams, is a good choice. And the only reason not to give it would be if there'd been some bad reaction to thiazides in the past, or if he had, excuse me, hypokalemia or borderline hypokalemia here. So switch the rather feeble dose of hydrochlorothiazide to chlorthalidone, which has a half-life of 42 hours, and therefore, even if he is somewhat non-compliant with his medication, which is very likely, even if he takes this every other day, it's still going to have a pretty good effect. Any questions about this case before we go on? Okay. So a little bit more information about some of the things you should look for in a case of severe hypertension. So we've confirmed that the blood pressure is high despite 30 minutes of rest. Are there any symptoms that might be attributable to blood pressure? And these are symptoms. They're not in themselves sufficient to diagnose emergent hypertension. The symptoms include headache, atypical chest pain, shortness of breath, dizziness or lightheadedness, or nosebleeds. And these are all symptoms that would suggest this is a little bit more than just benign hypertension and needs a little bit more attention, but not admitted to the ICU and urgent intravenous treatment. So if they're present, it's still a hypertensive urgency, but we want to make sure that we get the patient a rapid oral agent to clear up this problem, hopefully, and adjust the long-term medications and discharge when the blood pressures come down a bit and follow in 1 to 7 days. So just make sure that the patient is given some effective therapy while in the clinic. So what are the factors to look for that may have precipitated acute severe hypertension? Almost everybody will have pre-existing hypertension. And if not, you need to think of one of these more acute phase things here we'll talk about in a moment. Often the patient's not taking the medications prescribed. And here, it is worth asking some direct questions to see if you can understand whether the patient's having problems with the medication, because they often say they're taking them. But if you say, have you noticed headache? Have you noticed sleepiness? Have you noticed loss of sexual performance? Have you noticed difficulty with exercise? Some things that the patient may be blaming the drugs for, you can sometimes get them to own up, perhaps, to not being fully compliant and to change their prescription. An increase in dietary salt in somebody very salt sensitive can raise the blood pressure by about 20 millimeters systolic. There are certain drugs that raise the blood pressure, notably cocaine and amphetamines when they're taken in sympathomimetic amines in the form of nose drops in people who are in the season when people have got upper respiratory infections can be a problem. And in some people can be enough to raise the blood pressure quite a bit. Non-steroidal agents will raise it, not usually severely, and estrogens used to be a problem, but nowadays the dose of estrogen in the birth control pill or the pill for postmenopausal women is quite a bit lower and doesn't usually raise the blood pressure, certainly to severe levels. Of course, the patient may be anxious and you need to assess that. There may be something going on, such as acute heart failure or acute stroke, and this could either be a cause or a consequence of the high blood pressure, and you certainly need to think about it. And then there are 4 conditions that are important because they are conditions in which the blood pressure can go up, but the patient is not previously hypertensive or very hypertensive. Acute glomerulonephritis, occasionally, preeclampsia, for sure, pheochromocytoma, or scleroderma renal crisis. And these are important because the patient will not have accommodated to the high blood pressure. So relatively modest levels of blood pressure, a systolic pressure of 160, 170, 180, may cause significant problems, for example, hypertensive encephalopathy. And we know that to be the case, for example, with preeclampsia. So in these situations, even a lesser rise in blood pressure should be taken seriously. So what should you do? You should do a basic metabolic profile, a blood count. Importantly, ask for a blood smear to look for schistocytes if you think the patient may have vasculitis, malignant hypertension, or scleroderma. Because schistocytes imply that the blood is perfusing vessels with damaged endothelium. And damaged endothelium leads to vasoconstriction and rise in blood pressure. Always get the urine analyzed, do an EKG and a troponin, and there are other tests that may be indicated in special circumstances. For example, if you think the patient has an aortic dissection. So let's talk for a little bit about the blood flow to the brain, which is often the critical variable here. The brain blood flow is regulated by two factors. An increased neuronal activity or a decreased blood flow leads to the accumulation of carbon dioxide in that region of the brain, a local acidosis and vasodilation. And that is a very strong and rather specific cerebral vascular response. And it's the reason, for example, that on MRI, you can see areas of the brain that are being used. For example, the visual cortex, when a patient is looking, opens their eyes and is looking at an object, you can see with MRA increased blood flow to that region. And it's due to the CO2. And the other side of the coin is it's why the anesthetist, if the patient is undergoing a neurosurgical operation beginning to bleed, the neurosurgeon may ask the anesthetist to hyperventilate the patient, which will lower the CO2 and cause cerebral vasoconstriction. And the second factor is the myogenic contraction, so that when the blood pressure goes up, the vessels contract, it maintains the flow. And when the blood pressure goes down, they relax and it maintains the flow. This is autoregulation, we'll talk about in a moment. Unlike other organs in the body, the brain is entirely unresponsive to angiotensin and norepinephrine. And in the laboratory, if we infuse angiotensin 2 in a high dose, or norepinephrine, directly into the carotid artery, the blood flow to the brain does not go down at all. And the same has been done in human subjects, incidentally. So these are the factors that determine cerebral blood flow. And cerebral blood flow is very important because the brain has a very high rate of oxygen usage and a very low partial pressure of oxygen. The PO2 of the cerebral cortex, when we measure it in rats or mice, in the most well-oxygenated area, is only about 22 millimeters of mercury. Whereas in the kidney, for example, the outer cortex of the kidney, it's 50. So it's perilously near ischemic levels, and the brain cannot withstand, as you know, an interruption of blood flow for more than a few minutes. So autoregulation maintains blood flow during changes in perfusion pressure, and it normally protects the brain from barotrauma during hypertension or ischemia during hypotension. But the level at which the autoregulation is set gets reset after a day to a week of a change in blood pressure. So if we look at the autoregulation curves here, in which blood pressure is shown here and blood flow on the y-axis. In a normal subject or a normal animal, the blood flow to the brain is incredibly constant, really to 1 or 2 millimeters of mils per minute flow, as you change the blood pressure over a quite wide range here. When it gets to a certain level, then the autoregulation is exhausted. In other words, the vessels are fully dilated, and then flow falls with pressure. This is the dangerous range. When it gets to a particularly high level, in other words, the vessels are strongly constricted, then flow increases with pressure. And this is another dangerous situation and leads then to hyperperfusion of the brain, diffuse capillary injury, and cerebral edema. In patients with hypertension, the curve is well maintained here. The normal patients can autoregulate very well, but shifted to the right to cope with the normal level of blood pressure that that patient is experiencing. And as I mentioned, it takes about a week, a day to a week to reset. So if you have a hypertensive patient and you lower the blood pressure too quickly, they're not going to be on this curve yet. They're going to be on this curve, and they may have symptoms of lightheadedness and dizziness and even pass out at a blood pressure that's not dramatically lower than, well, let's say a systolic pressure of about 100, whereas most normal people can sustain a systolic blood pressure of 90, 85 to 90 without too much trouble. It varies. So cerebral autoregulation, it's important to recognize that increased CO2 overrides autoregulation, and that will come apparent when we deal with stroke. So evaluation and management of severe hypertension with acute organ damage, emergency hypertension. Just to recap, admit to the ICU, start IV without delay, lower blood pressure according to the pattern of organ injury. We'll talk a bit more about that. And start or resume long-term medications fairly early on, because you want to get the blood pressure down and the patient out and on an oral medication within the first day or two. So there are a number of situations that can lead to hypertensive emergency, of which hypertensive encephalopathy is one of the worst we'll talk about. Hypertension with cerebral hemorrhage, with acute dissection of the aorta, left ventricular failure, unstable angina, eclampsia, or situations in which there's catecholamine excess, such as pheochromocytoma crisis, tyramine-containing foods, and somebody is taking an MAOI, and as you know, the psychiatrists have got keener again on prescribing these drugs, so we'll probably see some more of this. And clonidine withdrawal. Patients who have been on a full dose of clonidine, it's suddenly stopped, or they become ill and don't take it, can get what is very like a pheochromocytoma crisis. And it's due to sudden restoration of high-level sympathetic drive, which had previously been damped down by clonidine. So let's look at this case. A 50-year-old man with prolonged hypertension admitted with 6 hours of severe headache, right-sided weakness, and hemianopsia, typical capsular hemorrhage. He has a high blood pressure, and the CT shows a capsular hemorrhage with midline displacement. So this most definitely is an urgency, right? An emergency. So your initial management should include admitting to hospital, of course, and cautious reduction in blood pressure to a goal just above normal in the first 1 or 2 hours, or no reduction of blood pressure in the acute phase. So think what your answer to this would be for somebody who has a cerebral hemorrhage, okay? And we'll come and answer it for ourselves in a minute. So this is the situation here. The CT of the brain showing blood in the CSF and a bleed. And a little bit later, there's far more blood in the CSF. The midline is shifted right across here. There's no doubt this man or lady has got a very severe rise in intracranial pressure and is in danger of coning. And all this blood here, which is spread out into the brain, is going to cause likely permanent cerebral damage, even if the patient survives. So we want to stop this translating into this. Okay, that is the acute problem. So this is the section through a brain with a patient such as that. So ask yourself, what is this structure here, do you think? Here's the brain tissue, right? Neurons, etc. Here's an artery. What is this, do you think? Now you notice it has blood in it. Here's some old clot, and here's some real blood here. You notice that it has a break in its wall here. The wall is very thin, and it's broken, and blood has escaped into the brain here. Old blood that's clotted, and there's some fresh blood. And it communicates, here's the artery. So it's not an artery, but it's an aneurysm on the artery, a so-called Charcot-Bouchard aneurysm, which develops in patients with sustained prolonged hypertension. Here's the artery itself, and you can see it's the thickness of the wall here, much greater than the thickness of the aneurysm here, and that's why it's prone to rupture. It communicates directly with the blood at arterial pressure. So your life-saving measure for this individual would have been to prevent more blood escaping from this ruptured aneurysm. And the two ways that you might do it, one would be a neurosurgical procedure, perhaps, to try and clip this off or thrombose it off in some way. But emergency treatment would be to lower the blood pressure, because a lower pressure gives the patient more chance that the blood will clot and less pressure to expel the blood into the brain. So lowering the blood pressure is the key event early on in a patient with an ongoing cerebral bleed. Okay, this is the typical situation that we see in a relatively young, let's say 40, 50, 60-year-old patient with prolonged hypertension. But cerebral hemorrhage is also common in elderly patients. And here's the section through cerebral blood vessels in an elderly patient. And you'll see the vessel here, and what's missing really is any real evidence of nuclei in the vessel wall here. And you'll see here a few nuclei here, but large patches where there's really nothing in the wall except this waxy material, which is apple green on when you shine polarized light on it. In other words, this is amyloid. And it's not systemic amyloidosis, it's local cerebral vascular amyloidosis, which occurs in elderly patients, often accompanying early Alzheimer's disease, but can occur just as an aging process. You can imagine this vessel wall is also very weak. There's not actually an aneurysm, perhaps, but it's very prone to rupture because it's lost the resilience of the elastic lamina and the muscle layer. And the treatment, therefore, would be the same as in the patient with the aneurysm. Now, there's very little controlled randomized clinical trial in the field of urgent and emergent hypertension because, by definition, it's sort of unethical to withhold treatment or to give anything other than the best treatment in a life-threatening condition. But here, the investigators randomized people to intensive versus guideline reductions in blood pressure in the first 24 hours after an acute cerebral hemorrhage. And they looked at the rate of intracerebral hematoma growth in the period. And you can see even a relatively modest further fall in blood pressure, to about 146 compared to 157, reduced the hematoma formation by about 50%. And giving some credibility to my recommendation then that you lower the blood pressure acutely to less than 150 systolic in the first hour or two in a patient with an acute intracerebral hematoma. So here we have that patient then, without going over it again. So cautious reduction in blood pressure to a goal of 150/95 in the first 1 to 2 hours, that's reasonable. And no reduction in blood pressure in the acute phase, no, because you've got to lower the pressure and stop the pressure head of blood that's jetting the blood through the ruptured artery into the brain. If the patient becomes symptomatic as you lower the blood pressure here, you've got to stop and gradually return towards a higher blood pressure and try again. And it may be difficult to achieve this level in 1 to 2 hours, but that should be a reasonable goal. So here's a younger man with 10-year history of hypertension, treated with a diuretic and ACE inhibitor, admitted with 3 days of headache, intermittent double vision, and slurred speech. So there's something going on in the brain here that's acute. On exam, he has a very high blood pressure for sure. He has swelling of the optic disc with hemorrhages and exudates in the fundi. He has renal damage with a creatinine of 2.8 and 1+ blood and 2+ protein in the urine. So first of all, what could the diagnosis be? Could it be acute glomerulonephritis? It just sort of could. I mean, he's got problems, he's got urine changes, he's got raised creatinine, he's got severe hypertension, although it's not a very common presentation, but it could be. Could it be hypertensive encephalopathy? And hypertensive encephalopathy is cerebral edema and impaired cerebral function because of overperfusion of the brain. And that would make a good case here, because where you see papilledema, you know then that the swelling of the optic disc, and it can either be due to a local inflammation of the nerve, which occurs in optic neuritis, for example, but in this setting, it occurs because there's raised pressure in the brain, which increases the pressure in the central vein of the renal nerve, the optic nerve, and causes swelling of the optic disc. So this implies then that there is raised intracranial pressure. And what you see in the retina is what's going on in the brain. So you know that there's damage to the small vessels. So could this be malignant hypertension? And we'll come back to that later. It's a special, hypertensive encephalopathy is a special complication of malignant hypertension. So should we reduce the blood pressure gradually over 2 to 3 weeks to this level? Or should we reduce the blood pressure in the first 1 to 2 hours to a close to normal, just above normal value if tolerated? Well, certainly it's a hypertensive emergency, isn't it? Because his brain function is potentially critically impaired. So we need to do something acutely. Let's think what. So here is the patient. He's on this curve here because he's got established hypertension, but we believe he's had an acute rise in blood pressure for whatever reason. He's hyperperfusing the brain, which damages the endothelial cells and leads to edema of the brain besides diffuse capillary injury. That is hypertensive encephalopathy. So that's what I've just said. So the management of encephalopathy requires rapid blood pressure lowering, and the signs and symptoms usually reverse very quickly while the blood pressure is going down. On the other hand, If the patient gets worse and begins to develop stroke-like symptoms, it means you've probably got the diagnosis wrong, and this really is an acute stroke in evolution, and you may need to raise the blood pressure again and reevaluate. But more usually, you've got it right, you believe, and so you aim for just above normal blood pressure in the first 1 to 2 hours and reevaluate. So malignant hypertension, it's a horrible term because this, malignant we really reserve nowadays for a special form of cancer after all, which this is not. But nobody's come up with a really very satisfactory alternative, so that's what we'll use. It's severe hypertension with vascular damage and retinal changes of hemorrhages, exudates, and papilledema. So please do not make a diagnosis of malignant hypertension without looking in the eye. And look yourself and call the ophthalmic team to come and dilate the eye and look in and be sure, because that's a critical part of the diagnosis here. A patient often is developing renal insufficiency, which progresses over the course of days. By definition, they have encephalopathy. They've got the signs here of raised intracranial pressure and damage to the small blood vessels. They often have a more widespread microangiopathy, and that can manifest as a degree of hemolysis and a raised LDL and the presence of schistocytes in the blood. So remember, look in the eyes and do a blood smear if you think it may be malignant hypertension. But really, the diagnosis is a pathological one. And this intimal proliferation of small blood vessels, onion skinning in other words, and fibrinoid necrosis of capillaries, leading to ischemia, edema, petechial hemorrhages, and infarction of downstream organs. The pathophysiology is a little special too, because whereas most patients with hypertension have a degree of volume expansion, not very evident often, these patients, because of the acute and severe rise in blood pressure, can have ECV depletion. And because there's this onion skinning here and ischemia of the glomeruli, there's intense activation of the renin-angiotensin axis, which leads to more vasoconstriction in the kidney, more release of renin, a vicious cycle, and a breakdown of autoregulation. So in this particular setting, we don't want to cause further volume depletion and renin stimulation, and we avoid the use of diuretics in the acute phase. Let's move on because I'm getting a bit. Here's a picture of onion skinning and fibrinoid necrosis in a small blood vessel. And let's look at the pictures of some fungi. This is a normal fundus, I hope, because it's mine, and taken with a fundus camera. And you look for the 4 quadrants. You look for the arteries and the veins. The artery should run straight out, and at a similar radius, it should be at least 2/3 the diameter of the vein. Mine is a little bit thin, and indeed I have hypertension, so it's not entirely normal. It's a hypertensive retina. You look at the margin of the retina, and it's very clear. On the nasal side, it's often a bit blurred. And if you're not really sure if the patient has papilledema, look at the central retinal vein here. And if you've got a really good eyesight, you can see it should collapse during diastole and become fully ballooned during systole. And if it doesn't do that, it means that it's being kept open by high pressure. And that suggests there's early cerebral edema and early papilledema. So here is papilledema. You can see the disc margins are gone, the disc coming out towards you, the vessels are humped over it. You can see how they hump here. And the arteries, you can see in a lot of spasm here, and you lose the arterial blood column altogether at points. So here's another one showing again the loss of the disc margin here, some nipping of the blood vessels as they pass over each other. And hemorrhages doesn't show very well here, it shows better. Here's exudates, badly named because hard exudates like this are not really exudates, they're areas of retinal infarction. That's important to know because if the patient has infarcted areas of the retina, once it involves the macula, they're going to lose sight. So that's a very important sign that you must get moving on this patient quickly. Again, edema of the optic disc. And here's another one, again, very severe papilledema. You can hardly see the disc, the artery with a lot of spasm, and these flame-shaped hemorrhages here, which are very typical of malignant hypertension, spreading out in a radial distribution together with some exudates or edema here. This could be a soft exudate here. This truly is edema. So here's another case quickly, a 40-year-old man with 10-year history. Oh no, this is a case that we had, excuse me. So as we said, it could be any of these. Since he has hypertensive encephalopathy and malignant hypertension, we want a quick reduction in blood pressure to just above normal in the first few hours here, rather than a slow reduction over weeks. The first possibility. The second one is correct. So scleroderma renal crisis is functionally almost identical to malignant hypertension. And in fact, when you look at what's going on in the kidney, it's almost identical too. And both of them, we need control of hypertension to prevent progression of renal failure. ACE inhibitors are often highly effective and avoid initial use of diuretics. So hypertension with acute aortic dissection, the aim is not to lower the blood pressure, but to lower the shear on the aortic wall. And the shear force is determined by the contractility of the left ventricle. So the first drug that you use should be something that reduces cardiac contractility. In other words, a beta blocker or perhaps a calcium channel blocker, and not a vasodilator, which may cause reflex stimulation. So your first drug may be a short-acting beta blocker, such as esmolol, and then replace it with a long-acting oral drug. And then once the heart rate is slowed and you're sure the patient's properly beta blocked, you can lower the blood pressure more effectively with a drug like nitroprusside. So finally, nitroprusside is often chosen because it's very reproducible, but you should avoid it in acute MI or angina because it causes reflex stimulation of the heart, and nitroglycerin, a beta blocker, is preferred. In an adrenergic crisis, such as pheochromocytoma, you need labetalol is often a good choice. Phentolamine is a pure alpha blocker, but labetalol or carvedilol work well. Dissecting aortic aneurysm requires a beta blocker first. Eclampsia is treated with hydralazine and labetalol, plus or minus nifedipine typically. And patients are often on alpha-methyl-dopa because they have pre-existing hypertension. And if there's any danger of developing true eclampsia with fits, the specific drug is magnesium sulfate. And avoid diuretics in malignant hypertension. So this is the last case, an old woman, past history of hypertension, several mini strokes, admitted with 5 days of confusion, slurred speech, dribbling of saliva, worse hiding headache. In other words, a stuttering hemiplegia. And this is a typical thrombotic stroke then, progressing, high blood pressure. So what should your management be? Cautious reduction in blood pressure to just above normal in the first day, no reduction in the acute phase, or reduction in blood pressure only if thrombolytic therapy is required. So here's the physiology behind it. This patient is in this phase here. the artery is thrombosed, and the thrombosis is likely spreading. So the brain is underperfused, and the CO2 is accumulating, and the blood vessels that are functioning are maximally vasodilated. So the local flow of blood to that region of the brain is no longer autoregulated, but depends on pressure because the vessels are held open by CO2. Therefore, it's dangerous to lower the pressure in the case of somebody with a stroke in evolution, a chronic stroke like that, semi-chronic stroke. It's quite different from the cerebral hemorrhage. So here then, no reduction in the acute phase and some reduction if thrombolytic therapy is required, but it's not likely in this because it's been progressing over 5 days. So the last slide, differentiate between emergencies and urgencies. Examine the fundi carefully and always perform a urinalysis. Ask for a blood smear for schistocytes if you're considering malignant hypertension or scleroderma. Select a target blood pressure and target time for its achievement, and thereafter reassess regularly and write fresh orders. Write in the charts what monitoring you require, and you'll select an initial target blood pressure that's a little above normal. Never try and fully correct a severe situation to normal in the matter of minutes, because you may have got the diagnosis wrong and you may have to reverse track here if it wasn't, for example, a cerebral hemorrhage, but really a cerebral thrombosis.